Management of CTDs 1 General Principles. These set the foundation for long-term control and patient empowerment. Early diagnosis and monitoring. Why? CTDs often present subtly, fatigue, arthralgia, rashes, so early detection prevents irreversible organ damage. Example, ANA positivity with low complements and proteinuria, early lupus nephritis. Tests, ANA, ENA, anti-LA, anti-SM, anti-RNP, ESR, CRP, CBC, LFs, RFTs, urinalysis. Multidisciplinary approach. Why? CTDs affect multiple organs. No single specialty suffices. Example, a patient with SLE may need rheumatologist, systemic disease, dermatologist, malar rash, discoid lesions, nephrologist, lupus nephritis, pulmonologist, pleuritis, ILD, cardiologist, pericarditis, pulmonary hypertension. Patient education. Why? Compliance is key. Flares often follow poor adherence. Example, teaching about steroid tapering, sun protection in SLE, and red flags like hematuria or dyspnea. Lifestyle modifications, avoid smoking alcohol, reduces vasculitis risk, improves drug metabolism. Balanced diet, exercise, prevents steroid-induced obesity, osteoporosis. Sun protection, crucial in SLE to prevent flares. Stress management, stress can trigger flares, mindfulness and CBT help. 2. Symptomatic treatment, targets immediate symptoms while disease-modifying agents take effect. NSAIDs, use, arthritis, myalgia, serositis. Caution, avoid in renal disease or GI ulcers. Example, RA patient with morning stiffness, NSAIDs improve function. Analgesics, use, chronic pain, fibromyalgia overlap. Example, tramadol or acetaminophen for non-inflammatory pain. PPIs, use GERD in systemic sclerosis. Why? Esophageal dysmotility is common. PPIs prevent strictures. Calcium channel blockers, use Raynaud's phenomenon. Example, nifedipine reduces vasospasm and digital ulcers. 3. Disease-modifying treatment. These suppress immune activity and prevent progression. Corticosteroids, use acute flares, organ-threatening disease. Example, lupus cerebritis IV methylprednisolone. Monitor, glucose, BP, bone density, infection risk. Immunosuppressants, methotrexate, RA, skin lesions, mild systemic features. Azathioprine, mycophenolate, lupus nephritis, systemic disease. Cyclophosphamide, severe vasculitis, ILD, renal crisis. Cyclosporine tacrolimus, refractory dermatomyositis or lupus. Biologics, rituximab, B-cell depletion in RA vasculitis. Belimumab targets BLIS and SLE. TNF inhibitors, RA, psoriatic arthritis, overlap syndromes. 4. Organ-specific management, tailored therapy based on organ involvement. Renal, lupus nephritis, mycophenolate or cyclophosphamide steroids. Scleroderma, renal crisis, ACE inhibitors, e.g. captopril, are life-saving. Lung, ILD, cyclophosphamide or mycophenolate. Pulmonary hypertension, sildenafil, bosentan improves exercise tolerance. Skin fibrosis, scleroderma, methotrexate, UVA1 phototherapy, reduces collagen deposition. Muscle disease, polymyositis, dermatomyositis, high-dose steroids, MTX, IVIG for refractory cases. Example, proximal muscle weakness plus elevated CK, treat early to prevent disability. 5. Supportive management, improves quality of life and prevents complications. Physiotherapy and rehabilitation. Why? Prevents contractures, maintains mobility. Example, scleroderma patient with hand stiffness, daily stretching. Occupational therapy, use adaptations for daily tasks, e.g. grip aids for arthritis. Bone protection, steroid users calcium vitamin D bisphosphonates. Example, RA patient on long-term prednisolone, Dexascan plus alendronate. Vaccinations, before immunosuppression, influenza, pneumococcal, HPV. Why? Prevent infections in immunocompromised patients. 6. Monitoring and follow-up, essential for adjusting therapy and detecting flares. Disease activity score, SLID-I, tracks lupus activity. DS28 for RA, tender swollen joints, ESR-CRP. Regular labs, CBC, CRP, inflammation, cytopenias. Renal, liver function, drug toxicity, disease activity. Autoantibodies, monitor seroconversion or flare risk. Imaging, HRCT, ILD progression. Echo, pulmonary hypertension, MRI, myositis, muscle edema, inflammation. Summary equation management equals lifestyle, symptom control, plus immunosuppression, plus organ protection, plus monitoring. Goal, control disease activity, prevent organ damage, and maintain quality of life.